Hello, everyone. Happy Tuesday. I'm really excited for this session. Welcome to CP Solver's second Intern Boot Camp session. We're really excited for these sessions because it's an opportunity to kind of review high-yield topics that residents will encounter in their intern year in a totally safe and fun environment. So I'm really excited for the session today. The topic of the second intern boot camp session covers a few things. We're going to cover troponin elevations. We're going to cover myocardial injury and ischemia. And I'm really excited because we get to learn from both myself and the incredible Yusuf and Mark. So my name is Maddie, for those of you who I haven't met yet. And I will pass the mic to Yusuf and then to Mark. But then before I do, just wanted to give you all a heads up that this is going to be an interactive session. So we're going to have some breakout rooms to discuss some questions that we have. As I said, it's a totally safe learning environment. And if you can't join a breakout room, that's no problem. You can just stay in the main room. All right, mic to you, Yusuf.
Hello, everyone. I'm Yusuf. I'm a third-year resident and a CP Solvers member. Very excited for today. Before starting residency, I had no idea how to approach troponin. I just know like, oh, there's MI and not MI. But I feel like after going to residency, I kept learning things, and even preparing for this session, I learned a lot. So the journey of learning is still ongoing. Very happy for you, all of you joining us today. Look forward to discussing it with you. Mark?
Hey guys, I'm Mark. Also a third-year resident, one of the CP Solvers members. Like Yusuf, I'm definitely very scared of chest pain and troponin elevations as an intern. But I just want to stress you guys, you will see this almost every day in the hospital, especially as interns. You guys will begin the first call from, the team about a chest pain in one of your patients. So it's just very important to have an organized approach to these problems. So super excited to talk about this.
And speaking of real life examples, all the cases today are from my internal medicine rotation from the past few months. And if you're ready, Mark, and Maddie, I can read through the case. Okay. So I was on a cross cover service on night float, and for those who don't know, night float is basically the team that covers the hospital. You basically float from patient room to patient room and take care of patients overnight. And I was actually in the parking lot, leaving my car, walking to the hospital, when I get a call like, hey, one of the patients you're covering for is having chest pain. So I run up to the computer quickly to chart a review before seeing the patient. So I see that it's a 60-year-old female. She has a history of diabetes, hypertension, and a recent diagnosis of ovarian cancer. And I quickly go into the room, and the initial vitals were a heart rate of 90, a respiratory rate of 20. She was on 3 liters nasal cannula, and the oxygen saturation was 95%. And the blood pressure was 90/60 with a MAP of 70. She reported left-sided chest pain with no radiation. And when I quickly looked through the chart, she was not on oxygen prior to me evaluating this patient at that moment. So Mark, I'm going to throw the first adequate to you. What is your approach to chest pain? Are you scared? What workup would you like? And how do you think about this?
Do you think now's a good time to go into breakout rooms now? Yeah.
Okay, I'll set that up. So give me 1 second. I'm going to do 3 big breakout rooms. Okay, create, open all rooms. All right, so you all should see a breakout room. And if you're able to join, go ahead and join.
– Everyone back? A lot of participants today. Awesome. All right, I'm sure you guys talked a lot about this alcohol. This is a very rich question, but I'll just call on a few people to share some of your thoughts. I'll see people at the top. Umbish, are you in a good place to unmute and just talk about what your group talked about? about chest pain and your guys' approach to chest pain?
Hi, Mark. I'm sorry. I just entered and I'm a little lost. I know there's a discussion going on, but I don't know what was going on.
No, no worries, no worries. Marina, are you in a good spot to unmute?
Oh yeah, for sure.
Awesome.
Hello everybody. Long time no see. So basically in the group, Ibrahim was stating that basically the approach or to make a good diagnosis, we have to rule out first the emergent causes with the 4+2+2 mnemonic. But then we had a good discussion about what should we think when we are in the hospital setting. So base rate wise, we should think first, considering her history of her age, she's 60, type 2 diabetes, hypertension. We should consider the fact that maybe she could be presenting an atypical presentation of MI or something like that. So it will be very good to get some basic workup of ECG, troponins, even a chest X-ray or whatever. And also the fact that she has ovarian cancer and she's hospitalized. We were thinking about also hypercoagulability, that she has an increased chance of that. So basically that was the main discussion of our group.
Awesome, awesome discussion. I like how you highlighted the setting that you're in, right? Acute chest pain in the outpatient setting is a little different than acute chest pain in the hospital. And most of you guys are probably going to be interns next year and probably spend most of your time in the hospital. I'm going to get most of these calls. So I like how you stratified based on where the patient was at and kind of the initial labs. Great. Who else? Simi, are you in an okay spot to unmute and talk about your groups, what you guys talked about?
Yes. So we were just talking about chest pain and what all goes around. Maybe we were thinking because the patient has a history of ovarian cancer, there were thoughts about thinking about either thrombus or like pulmonary embolism or hypercoagulable state. So that was something that we were thinking. And these are the things like main highlights, but if anybody else from the team would like to add on if we discuss anything.
Yeah, no, that's great. You're using the, past medical history to kind of layer into the presentation, which is awesome. And kind of going back to you, Marino, too, and I'm sure a lot of people might have talked about the 4+2+2, but there might be new people to the 4+2+2 mnemonic here. And honestly, I feel like this is one of the original CP solver schemas, and to this day, I still use it every single day in the hospital. It never fails. So does anyone want to talk about the 4+2+2 and those causes? You can either write in the chat or unmute.
Okay, so I guess I can go. So so this is a CP solver schema where you basically rule out the emergent causes and they are based on the organ involvement. So the 4 causes are related to cardiac involvement, and then you have 2 causes related to pulmonary involvement, and the last 2 ones are related to esophageal involvement. So the cardiac causes would include things like ACS or MI, aortic dissection and tamponade, as well as Takotsubo. And then for the 2 pulmonary would include things like PE and pneumothorax. And finally, for esophageal, it would include the 2 most common causes, which are rupture or impaction in the esophagus.
Beautiful, perfect. 4+2+2. And I want you guys to memorize that. Wake up in the middle of the night saying that 4+2+2, because I want you guys thinking every time you go evaluate a patient at the bedside, have that 4+2+2 in mind, because those are the things you want to diagnose right away, right? As soon as you get to the bedside. And that's how you're going to tailor your history and physical exam, right? Because those are the things you want to diagnose first. So what else would you guys want to know on history and exam to see if any of those 4+2+2 are at play? And I'll say and this might be just where I trained, but in medical school, I learned that Socrates mnemonic. Did anyone learn that for asking about pain? Like, different qualifiers for pain. Did anyone learn about that? I still use that. And it essentially stands for, I might be getting some of these wrong, but site, right? Where is the chest pain? Onset, when did the chest pain start? Characterization, is it a squeezing? Is it a stabbing? Radiation, right? Is it radiating to the back? Like that's common in an aortic dissection. Is it radiating to the left arm, which can be suggestive of an ACS event, right? associated symptoms, timing, severity. So I always go back to that Socrates because I think it kind of helps you organize your history taking, right? So how would you guys expect, like starting with ACS, something that we'll probably talk about a little bit today, what do you expect the history and exam to look like in acute coronary syndrome? It could be, STEMI and STEMI. What do you guys expect on history? History of Alina, yeah. And Alina, you're getting at some, it seems like risk factors, right? You're saying CAD. Any other risk factors for coronary artery disease that you know of? Hypertension.
So that would be diabetes. Yeah, sorry.
Oh yeah, I was just reading Tatsu. Sorry. Yeah. Yeah, perfect. CAD, hypertension. Yeah, and I'll say none of these are. It's great. Squeezing, right? A pressure sensation, exertion related. Perfect, Ethan. Could also be promoted by emotional stress as well. And I'll say, none of these are perfect, right? This just moves your pretest probability up and down, right? If a chest pain is more pleuritic, right, you can think of your P's, right? Your PE, pericarditis, pneumothorax, right? Maybe that makes ACS a little less likely. If it's sharp or tearing, maybe that makes you think of aortic dissection as more or less likely. But again, you have to filter in the labs, the past medical history, and that kind of moves the pre and post test probability up and down, right? And now, so we kind of talked about the 4+2+2. We're going to do a good history. We're going to do a good exam. And then moving on to some of our labs. If you were guys to say, if you're evaluating a patient with chest pain, right, at the bedside, what is 3 labs that you guys would like? Put it in the chat. If you were only to get 3 labs, what would they be for chest pain? EKG, troponin, trope, yep. Umbish added chest x-ray, yep, awesome. D-dimer I see, CK. D-dimer, great. Now, and one thing I want to stress to you guys, especially as interns, now, like taking I feel like the leap to intern year is to knowing how your tests operate, right? Knowing what it is, the weaknesses of the test, the strengths of the test, what's the sensitivity, what's the specificity. So outside of, let's say, actually, let's start with ACS first. And this is kind of a read my mind, but what percentage of patients that present with acute coronary syndrome have a non-diagnostic or normal EKG at presentation? What do you guys think? I see 80%. Actually, not that high, but it's higher than I thought. 40, almost perfect. So it's actually 40% in one study that I was reading. So that just highlights, guys, if that EKG is normal, but you're still suspicious for an acute coronary syndrome, get serial EKGs every 15 to 30 minutes if you're still concerned. Also get serial troponins as well, right? Because the first sign physiologically of acute coronary syndrome is not a troponin leak. That happens a little later in the ischemia cascade, right? So keep getting those EKGs and those troponins, right? And then kind of going further, what other causes of chest pain can an EKG be helpful, right? Because we're not going to just use it for acute coronary syndrome. How else get pericarditis? Okay, that's good, Tansu. Pericarditis, tamponade. Tansu, what are some findings in pericarditis, and how do they work out in terms of sensitivity and specificity?
I don't know the sensitivity and specificity, but we would expect the ST elevation to be diffused rather than like in specific leads that we see in ST elevation, myocardial infarction.
Yeah.
Yeah,
perfect. Perfect. And then kind of pushing it further to tamponade, right? Because tamponade usually is from pericarditis of some sort, and then you get tamponade physiology. You also can see low voltages too, right? And then you could also see electrical alternans. Those findings, honestly, though, less than 50% of patients. So if they're there, they're helpful, but if they're not there, they're not helpful, right? How else can EKG? I saw someone put right heart strain, PE. Yasmin, how good is the S1Q3T3 and right bundle branch block for PE, would you say?
I don't really remember, but I know that all of the signs don't have more than 20%. Like I know that S1QT3 is 20%, and the other ones are like 18, 16% of like specific.
Yeah, no, it's like 10 to 20% for the S1Q3T3. So, again, it's not sensitive. It's pretty specific for right heart strain. But the other things to look at for PE, sinus tachycardia is usually present. Also T-wave inversions too. So not all T-wave inversions are an acute coronary event, right? There's a longer differential, but commonly PE presents with T-wave inversions too. And then one other one that I'll mention is Takatsubos, right? One of the other 4 on the cardiac causes. It's a STEMI mimic. You can see ST elevations in the anterior leads, very common. You can also see T-wave inversion. So most cardiologists say you can't diagnose Takatsubos until you get a coronary angiography and rule out a plaque rupture as well. And then I'll just mention just a couple of things about chest X-ray. So what is chest X-ray good for in chest pain? Why are we getting that chest X-ray? Aortic dissection. I love how Tansu mentioned aortic dissection because I learned something very interesting about that. Pneumothorax. So Tansu, what are you looking for in the chest X-ray, and how good is it?
So I would expect mediastinal widening on chest X-ray in aortic dissection, but again, like I'm not sure about the test characteristics, performance of it.
Yeah, it's actually 80%. It's actually a decent test, especially in type A aortic dissections. It's 80%. I was very surprised when I originally learned that number. I thought it was going to be very low, very low. Pneumothorax, good. I saw pneumothorax. Pneumothorax is very good, or the chest X-ray is very good for pneumothorax. Tamponade, wide mediastinum. Just looking at other things. Yeah, and then also too, for even the esophageal cause, I feel like the esophageal cause is usually pretty apparent on history, but you also can get a widened mediastinum and then pneumomediastinum and even air under the diaphragm for esophageal perforation as well, right? And then I'll just say one last thing. You guys nailed it. The 4+2+2, chest X-ray, EKG, and tropes. And then the other test people mentioned is D-dimer. I won't go too much into it, but if you have a low pretest probability for a PE, a negative D-dimer is very good at ruling out PE. Another thing that D-dimer is actually pretty good for is aortic dissection. If you have a low pretest probability for aortic dissection and your D-dimer is less than 500 nanograms per deciliter, it has like a 96% negative predictive value. It's pretty good for aortic dissection as well. But if you start to lean in the moderate pretest probability, don't even think about it. Just get the CT aortic dissection protocol because that can be, deadly very quickly. Yusuf, you want to talk about the?
Do you want to talk about the likelihood of ischemia or not yet?
Oh, we kind of touched it. Just for time, maybe we'll move on from that. We kind of touched on that. Yeah.
Okay. So I saw the patient, and like Mark said, I ordered a chest X-ray, an EKG, a troponin, a basic set of labs, and let me share my screen and show you the EKG. This was the EKG. I'm not going to ask one person to read it, but if you can start putting in the chat what abnormalities that you identify, or if you want to unmute and say what abnormalities you can identify just from this EKG. Elena mentioning T-wave inversions, and which leads do you see them, Elena?
So I see them in 1 and 2 and 3 as well, and yeah, and more diffuse and in other elsewhere.
Okay. Same mentioning the ST depressions in 1 and 2. Good, and maybe some ST elevations a little bit in AVR, if you notice as well. So those was like and some tachycardia as well. So this was the EKG, and then we did a point of care ultrasound, which I'm gonna share as well. this was the point of care ultrasound. And for the right side of the screen is actually the left side of the patient. So it's inverted. But if you notice on the left side of the screen, it's almost the same size. Both chambers of the heart look almost the same size. And this is very, very abnormal, which is very concerning for right-sided disease, essentially. So the initial lab started trickling in. The chest X-ray was clear. The white count was 14,000, which was neutrophilic. The initial troponin was 569. The BNP was 841. And the lactic acid was elevated at 6.0. So now that we have this information, to summarize, some T-wave inversions diffusely, ST depressions in 2 and 3 with maybe an ST elevation AVR, a elevated troponin, elevated BNP, elevated lactate, and maybe evidence of right heart strain on point of care ultrasound. I'm going to create the second breakout room for you to discuss what is your treatment plan, any management you want to do right now before doing any diagnostics, and how would you document these troponin elevations in your note? So I'm going to create the breakout rooms right now. Welcome back, everyone. Anyone want to share what they discussed in the breakout room? Would love to hear your thoughts. Yeah, Hussein, please go ahead.
So what we were thinking about in our group was that we were thinking about two possibilities. One of them was a right-sided heart failure, because most probably from an MI, or the second thing was a massive PE that was causing the dilation and the right-sided strain. So we were thinking along those lines, and our management would have been like on would the next step would be to do further tests, most likely to confirm, to rule out a massive PE. We would go for a CTPA before making a final diagnosis.
Yeah, excellent. Anyone else want to share their thoughts?
So we were also talking about the PE as being our priority right now. And something that I learned in the ED is that actually if your suspicion is very high for a pulmonary embolism and the patient is hemodynamically unstable, you can actually do the 3-point POCUS of the leg to look like for a DVT. And if that's positive, you can actually start the heparin. But I think in the setting, it's very important to also like take a step back, and go through the 4+2+2 again. And then Sarah also mentioned like who would we want to get into the room like right now, like, for example, people like interventional radiology and maybe like ICU staff and anesthesiologists. And I think we also talked about the troponin and BNP, and that could also be like a past medical history of some sort of lung disease, because I think the atria were actually enlarged in this patient. So maybe this was due to like a long-standing pulmonary disease. Yeah, those are some of the points.
Yeah, good job, both of you. So this was like exactly like similar thoughts I had. Like, could this be a right-sided MI, or could this be a pulmonary embolism? So I called for help, exactly like you mentioned, which is the right thing to do in the situation. We spoke to cardiology as well, who also came in and did a point of care ultrasound, which like confirmed these findings. We started a heparin drip empirically, and we ordered a CTPE. Another question I had is, do you know the difference between type 1 and type 2 MI? And if not, I can go through the difference between the two. Perfect. So usually type 1 MI is due to spontaneous plaque rupture. It could be due to a fissure and erosion, but it's usually due to an intraluminal thrombus. While type 2 MI is due to supply-demand mismatch and not due to atherothrombosis. So it's commonly seen in many etiologies like sepsis, arrhythmias, pulmonary embolisms. And one thing I want to make note of is both type 1 and type 2 MI, there is evidence of ischemia. So the patient might have elevated troponin, they might have chest pain or EKG changes like this case, but it's not necessarily the similar mechanism. And it's very hard to think about it because we're differentiating between the two based on pathophysiology, not based on history or physical exam. That's the mechanism of it. So it can be very, very hard to differentiate between the two because if you think about it, if you have a very stressful thing in your body like sepsis, that can trigger a type 1 MI. So in these scenarios, you want to assume this is the worst, like a type 1 MI until proven otherwise. So oftentimes in these scenarios, you want to involve cardiology or the specialist to ensure that everything is getting worked up. There were studies to try to compare what factors can help you differentiate between the two. And in one study of 560 patients, the significant factors that predicted a type 1 MI were age, a history of prior myocardial infarction, the LDL to HDL ratio, and then the degree of troponin elevation and the percentage change in the troponin elevation. So these are the factors that make you think more towards type 1 MI. And type 2 MI, you must really have a clear precipitating factor. Otherwise, it would be hard to just call it off and not say this is not a coronary ischemic event due to type 1 MI. The other thing is, in patients with type 2 MI, even if they had a stressor like sepsis, 50 to 70% of those patients have underlying coronary artery disease. So in general, there are some institutions where if somebody has a type 2 MI, they go ahead and do a stress test once the stressor is resolved to make sure there's no any luminal occlusion. In this case, the patient did undergo a CTPE, and we found a saddle pulmonary embolism. Unfortunately, prior to further interventions, the patient had a code and she passed away, unfortunately. But hopefully we can learn from her case. Any questions about this portion or the part prior before we move on to the next case? Yeah, a good question. Did she qualify for mechanical thrombectomy? I think she would have qualified if she was stable or her blood pressure was stable, but I think her blood pressure dropped precipitously afterwards.
I have a question. Did the patient receive prophylaxis because in the setting of hospitalization?
Yeah, she was on low molecular weight heparin.
I had a question on the D-dimer. Sorry, maybe to Mark or to you, Joseph. I think when we were discussing the tests that we would order, the D-dimer came up. I think, oftentimes we hear that the D-dimer is frowned upon because if it's elevated, you need to find why is it being elevated. So would you recommend ordering that for every patient with chest pain, or only those where you still cannot figure an underlying cause?
From my end, it's usually if it's low risk, medium risk, or high risk for a pulmonary embolism. So if you're on the fence, you're not sure, maybe they have a PE, they probably don't. This is a scenario where I get a D-dimer. For example, in COPD exacerbations, and somebody has a first syncope, and I'm like, could this be a PE? Sometimes a D-dimer is a good sensitive test, but it's not a specific test. So anyone who has many comorbidities, it's high likelihood of PE, then I would, if I'm thinking about PE, I would just want to rule it out with the gold standard, which is a CTPE, for example.
Thank you.
And there was an amazing question in the chat, which is super complicated. And I think even intensivists will argue about this, about should we give fluids? Some people actually may argue to diurese a patient with a large PE. And you guys will learn as you go through residency that we're learned about these preload dependent states But actually worse is when that RV is not working well, it gets humongous and then it starts to bow into the LV. So you'll see, especially patients with really advanced pulmonary hypertension, we diurese, because that really does increase their stroke volume and cardiac output. I think just in the ends, and the biggest thing is to start this patient on like inotropate support, right? To support their RV with like epinephrine or norepinephrine, and then call the consultants that, Yusuf called, think about even giving, empiric TPA or getting the interventional radiologist to try to take out the clot. But that question is super complicated. And I feel like you'll get different answers talking to two different intensivists.
Okay, I'm gonna tell you all another case that I had. This one is actually from 2 weeks ago, like off my service. This patient was a sorry, let me open it up. There you go. A 60-year-old female with a history of diabetes, hypertension, presented to the hospital for nausea and vomiting. They reported 3 days of nausea, inability to tolerate food, subjective fevers, and right flank pain. She had urinary frequency as well. She had headaches, dizziness, intermittent chest pain. The vitals were notable for a temperature of 38.5, and the exam was notable for bilateral costovertebral angle tenderness. The exam was otherwise normal. So I'm gonna pause here and just ask, what is your differential diagnosis and what workup would you like? I'm not gonna open the breakout rooms at this juncture. Yeah, I like it. Pylo, UA, CT, perfect. So we did a urinalysis, which was notable for pyuria and bacteriuria. And the CT abdomen pelvis showed heterogeneous hypodensities in bilateral renal cortices, concerning for pyelonephritis without abscess. The initial labs were notable for a white count of 18,000 with 80% neutrophils, and the troponin was 85. This is a high sensitivity troponin. And this is the EKG. And if you see any abnormalities, you can put them in the chat as well. Yeah, exactly. It was sinus tachycardia. And we're gonna pause here for another breakout room. What do you think about this patient's troponin elevation? And how would you document it in your note in July, in basically 3 months? So proud of you all. How are you gonna write it in your note on your progress note? So let me create the breakout rooms.
All right, welcome back, everyone. So would love to hear from some of you what you all discussed. So, just to summarize here, we have this patient, this 60-year-old female who was coming in with urinary frequency, some nausea, vomiting. She was febrile, tachycardic, and had mild suprapubic tenderness and CVA tenderness with a mildly elevated troponin at 85, and then an EKG with sinus tachycardia. So I'm curious from the group how you all were thinking about this troponin level, given that there were no signs of symptoms of ischemia. Does anyone want to share what they talked about in the breakout room?
Yeah, I guess I can share what we were thinking. So without signs of ischemia, we were definitely thinking more like supply demand, like type 2 MI type of picture in the setting of sepsis versus possibly AKI, which is complicating the sepsis physiology, as well as the tachycardia. Troponin is something that is renally cleared. So those were our thoughts on what could be causing an elevated troponin. But we were unsure in sepsis in particular what causes the supply-demand mismatch.
Yeah, I love that. Anyone else want to share their thoughts before we dive into this topic a little bit deeper? Elena, what did your group talk about? I see your thoughts in the chat.
I was actually in Sarah's group as well, and she had amazing ideas. Yeah, it was just like with the sepsis, we're also like considering septic cardiomyopathy that would like elevate our troponin, and also you can have an AKI in that setting, so you won't be able to clear the troponin.
Yeah, those are both great thoughts. And so I think now's a great time to talk about myocardial injury and then the fact that you can have both ischemic and non-ischemic causes of it. So when you have an elevated troponin level, if the troponin level is greater than the 99th percentile of the upper reference limit, that is what defines myocardial injury. And so I've learned that with an elevated troponin, it's helpful to think of the two I's, ischemia and injury. So with an elevated troponin indicating myocardial injury, you can have ischemic causes and non-ischemic causes. So I wanted to ask the group, if we're thinking of this bucket of non-ischemic myocardial injury, you all have talked about it a little bit more, but kind of more specifically, what causes non-ischemic myocardial injury? Sarah and Elena have both mentioned some examples, but I want to see if others had some thoughts about what causes non-ischemic myocardial injury. I love it. I love it. So I'm going to show you a helpful figure, but just to kind of summarize a lot of the things that I'm seeing in the chat. So you can have non-ischemic myocardial injuries secondary to some cardiac conditions like myocarditis, myocardial contusion, cardiomyopathy, even a defibrillator shock. Or you can have non-ischemic myocardial injury secondary to systemic conditions such as sepsis, as in this case, or renal failure, or critically ill patients such as like a severe COVID-19 infection, and even some infiltrative diseases. So I'm going to show you an image just because I thought it was a helpful way to frame this concept. Can you all see this? Okay. So if you see that this kind of light pink here is showing the kind of the full circle of myocardial injury, and it shows increased cardiac troponins is kind of what's defining myocardial injury. And you can see within this larger myocardial injury bucket is a sub-bucket where you have ischemic myocardial injury. So all of this is really to emphasize that you can, within myocardial injury indicated by elevated troponins, you have both ischemic causes and non-ischemic causes. And some of the non-ischemic causes, as we talked about, can include, hypotension, shock, kidney disease. What's not on here is you can have like myocarditis, for example. So this is what I wanted to highlight, the fact that with an elevated troponin, it's not always indicative of ischemia. So let me go ahead and stop sharing this. Okay. And so what I've learned kind of preparing for this is that if there is no evidence to support the presence of myocardial ischemia, whether that's on EKG or from your clinical evaluation, a diagnosis of myocardial injury should be made. And one helpful way to distinguish between these ischemic causes of myocardial injury and non-ischemic causes of myocardial injury is the troponin trend. So if I wanted to pause here to see if anyone had any thoughts on how you think the troponin trend can help you in deciphering between an ischemic cause of myocardial injury and a non-ischemic cause.
I can go, Maddie. Generally, exponential increase in troponin with ischemic causes, just because you have a very large area of, myocardial necrosis with like a coronary occlusion. So the tropes will be very, very steep and they'll peak troponin. And the non-ischemic causes like infiltration, injury we were talking about, it's usually more of like a linear, slower increase in troponin.
Beautiful. Could not have said it better. And I'm just going to share another helpful image that was actually a schema that Robbie created that I think highlights this. So exactly as Andrew said, in the ischemic causes of myocardial injury, you're going to have more of a dynamic troponin trend. So it's going to be, if you can see these two images here, kind of a sharp incline and then a sharp decline. But in some of these non-ischemic myocardial injuries, such as myocarditis, infiltrative diseases, ESRD, the troponin trend is going to be more linear and not as dynamic. I wanted to ask the group if you all can think of any exceptions to that rule, as we know there's exceptions for almost everything in medicine. Any exceptions to that rule that you all can think of? So I can share, so that I just learned this today. So an exception to that rule is a late presentation of a type 1 myocardial infarction. We learned from Yusuf, that's when you have kind of the coronary atherothrombosis. So if you imagine the typical curve for troponin in an ischemic myocardial injury is dynamic. So it's sharp up and sharp down. But if someone has a late presentation of this MI, you might reach them if this is the graph, right? You might reach them, they might come in when it's here, so that the rest of the troponin trends are all going to be slightly downtrend, and you won't have that steep up and steep down. All right, any questions on that topic? If not, then we'll pass the mic to Mark to talk about some myocardial supply and demand mismatch.
Mark, can I add just one thing quickly? So just to recap as well, to differentiate between non-ischemic myocardial injury and type 1 and type 2. So troponin, no EKG changes, and no history is significant for ischemia. You think of non-ischemic myocardial injury. Troponins plus some EKG changes, but the history is notable for a secondary cause. You consider type 2 MI. While type 1 MI is the classic MI. And differentiating between type 2 and type 1 is hard. So if somebody has sepsis, I would call it non-ischemic myocardial injury, not type 2 MI, although they can have type 2 MI if they're having chest pain and symptoms, but in the setting of sepsis, like Maddie said, so the circles of sepsis can cross into MI, but mostly causes non-ischemic myocardial injury.
That was awesome, guys. And I'll just add one more thing before I talk about some physiology, is that what is the most common cause of death in patients with CKD? Does anyone know? And there's a reason why I'm asking this. CAD, right? So I think a really important thing, and I think it's something that's missed, is when patients come to the hospital with some sort of angina or anginal equivalent and they have ESRD, and we see they have elevated troponins, we say, decrease clearance, and maybe you look back at their baseline troponins, we say, oh, it's similar to the baselines. But unless you know exactly when someone got dialyzed and like, it's just too hard to honestly compare troponins in patients with ESRD because it depends on when they got dialyzed. It just emphasizes to always trend troponins because patients with ESRD commonly get MIs and CAD. Okay, guys, and the last thing we're gonna talk about some physiology. As some of you guys know, I love physiology, so I like to, wrap everything back to that. We've talked about supply-demand mismatch a lot. So what does this mean? We said this word a lot, but what is supply-demand mismatch? Maybe someone could send in the chat or unmute. And I'll say you can know essentially every cause of acute ischemic myocardial injury, that'd be type 1 or type 2, if you know the components of supply and demand. Good. Heart does not get the oxygen it needs to perform the workload. Perfect, Hans. Oxygen man with not enough supply. Perfect. And let's push that further. What are the components of oxygen supply? How does our heart get oxygen? Or how does our heart get supplied with oxygen? Some physiology equations we might have learned about a little bit ago. Vessel integrity, pump working normally. Hemoglobin, perfect, systolic blood pressure. Endothelial function being normal. The vessels, great, guys. And I'll say just two big things. The first thing is coronary blood flow, right? That's how we get, blood supply through the coronaries to the hearts. And there's two components of that. The one is coronary perfusion pressure, right? Which is your diastolic pressure, right? Because your heart fills, your coronaries are perfused during diastole, minus the left ventricle end diastolic pressure. So you guys could see if you're hypotensive and you have a low diastolic blood pressure, you can have a troponin elevation, right? Supply demand mismatch. If you have a high LVEDP, right, like commonly in patients with heart failure, again, you can get decreased coronary perfusion pressure and elevated troponins, right? And the next thing, so we said coronary blood flow is the perfusion pressure, and then also the coronary vascular resistance, right? And this is kind of the common causes of type 1 plaque rupture we think about, right? If you have a thrombus in your LAD, your vascular resistance is going to go up, right? Or what if you have vasospasm, like someone that's maybe smoking or using cocaine, they can get coronary vasospasm. That also can cause a troponin elevation. Or maybe someone has a spontaneous coronary artery dissection, right? Things like that, things that are affecting the coronary vessels. So blood flow is coronary perfusion pressure, coronary vascular resistance. The second big thing is that blood is only useful if it has oxygen in it, right? So the second thing is the arterial oxygen content. So this is a very important equation. But what makes up your oxygen content in your blood? There were some people mentioned it before. Anemia, hemoglobin is a huge contributor to your oxygen content. So if you're severely anemic, it's very common for patients to have, hemoglobin of 3 or 4 and have an elevated troponin because they don't have enough oxygen, right? Enough hemoglobin going to the heart. What's another component of it? Your oxygen content. So we got hemoglobin, two other big ones. We're going to get into that, Yasmin, the heart rate. We'll get about that. But what about the arterial oxygen content? What makes up the oxygen in the blood? Saturation. Perfect, Hussein. So saturation, those are the two, hemoglobin and saturation. So if someone's severely hypoxemic, they can also get a troponin elevation. And I'll say the other one, which is a small contributor, is the partial pressure of oxygen, the PaO2. That's a smaller contributor. And I'll put the equations in the chat too for you guys. So supply is coronary blood flow and arterial oxygen content. Okay. Now, what about demand? What are the components that increases the demand of the heart? There was a beautiful first aid mnemonic. I remember when I was studying for step 1, for all you that use first aid about this, the components of myocardial oxygen demand. Tachycardia, Tansu, perfect. Heart rate, yep, that's one. So if someone's say someone's, like we've mentioned before, AFib with RVR, that can definitely cause a troponin elevation. SVR, afterload, perfect. Someone has hypertensive emergency, they can also get a troponin elevation, right? And that's end organ damage from hypertension. Great. The medications that increase contractility, they meant perfect. So things like epinephrine or dobutamine, right? That stresses out the heart. And the last thing I'll just say is LV wall stress. It get back to like Laplace's law, right? But the mnemonic I remember is CARD, CARD, contractility, afterload rate, meaning heart rate, and diameter of the LV. Those are the things that increase demand on the heart. So just to summarize, guys, and I'll put the equations in the chart. You can know all the causes of ischemic myocardial injury, right? That being type 1 or type 2, if you know the components of myocardial oxygen supply and demand. So as opposed to just memorizing all these causes, if you just break it down to the physiology, the physiology will just take it from there. Any questions about that?
Yusuf,
Okay.
did you want to? Oh, go ahead.
Yeah, I was gonna go through just how to document the last portion of this session is how to document this troponin elevation. So in this case, we had a troponin elevation. The first thing I think of is, does the patient have chest pain or symptoms of ACS? So in this case, they don't have any nausea, vomiting, chest pain right now that's we think related to ACS. The second thing I think of is, are there EKG changes? The EKG changes that we think of are hyperacute T waves, ST elevations, deep Q waves, ST depressions, T wave inversions, a new left bundle branch block, or inverted T wave in V2 and V3, for example. So the other next thing I think of is, are there any signs of ischemia on EKG? And lastly, the third thing I think of is there a systemic condition predisposing to this troponin elevation, or is there an identifiable condition that I can think of that can tell me why the troponin is elevated? So in this case, for example, this is how I would document it in the chart. So let me share my screen. Yep. It would go something like this: non-ischemic myocardial injury. The patient presented with signs of sepsis and was found to have a troponin elevation. They don't have any signs of ischemia on history and EKG suggestive of ACS. The initial troponin was 85. The plan ordered to repeat the troponin until the peak and monitor for any signs of ischemia, whether through history or EKG. That's the end of my portion. So I was wondering if anybody has any questions or anything you wanted to discuss before the closing of the session. Okay. Well, thank you everyone for joining. We look forward to having this again in the future. Topic to be determined. If you have any requests, feel free to reach out to us here or on Twitter or anywhere. Maddie, anything you wanted to add? Mark, thank you both so much.
No, just thanks everyone for coming. Oh my gosh, my phone went off. Thanks everyone for coming, and Yusuf, Mark, your teaching is amazing, and I learned so much from you guys. So thanks everyone for being here.
Yeah, thanks everyone. Hopefully you guys can use this in a few months during intern year.
Bye.